And she's also the associate professor of San Francisco State University School of Nursing. She also is one of the publishers of the Packard Nurse magazine, and she's been published in various nursing journals, such as the Clinical Nurse Specialist, Journal of Nurse Staff Development, and Journal of Perinatal and Neonatal Nursing. So great resource if you want to publish something. So I wanted to say that before you, and thank you.
Thank you. Thank you.
So welcome to Nursing Grand Rounds. My name is Christina Rivera. I am the chair of our R&R, and happy Nurse Week. We want to welcome you. We want to try this out, having a Nurse Grand Rounds during Nurse Week, just to kind of highlight all the great work that our nurses are doing. We have 3 keynote speakers. You just heard one, Amy Nichols. Susan Costello will be up next, and we also have Lisa Grissom. So we have really, really great. We also have an expert panel of Charlene Lee and Elena Hopkins, so they will be up next, and 2 educational speakers, and that will round out our grand rounds. So next, I would like to welcome Susan Costello. She's our Vice President of Patient Care Services and Chief Nursing Officer. She brings more than 35 years of experience in the healthcare industry. Is it more?
Wow, she's very old.
38. In healthcare industry, ranging from nursing administration in academic medical centers, as well as consulting work in unionized and magnet environments. So we want to welcome Susan Costello.
Okay, and we need to turn off those lights. Okay. Black screen it would be sort of minutes. Yep, that's good. So I am the casual speaker for today. Yeah, we're videotaping, so I need to stay in front of the microphone so that it can be picked up. And I really want to thank you for the opportunity to chat with all of you. The focus of today is on nursing traditions and innovations. And to me, as I was thinking about what does that mean to me, I was thinking about the traditions that we learn in school, that we learn as we come into practice, and how they sometimes get in the way of our more innovative practices. So you didn't come in here anticipating a participatory event, but you're going to get one anyway. So my 2 favorite traditions, and I'm going to pick one that is a little less clinical and one that is very clinical. So I have this sentence I say when I give report, and it starts off with the name, age, sex, and date of admission. How many of you do that? Some, not all of you. They were admitted on the 1st. They were admitted on the 27th. You don't say those words? I'm surprised. I'm pleased. However, the usual purpose of that is to tell folks what the length of stay is. Now, I'm a reasonably bright woman, aged but bright. But when you get to the 3rd and 5th of the month and you tell me they came in on the 26th, I'm counting, because I got to go through the poem to find out whether or not it was a 30 or 31 day. And then I get to figure out, okay, what's the math of that? How many days have they been here? This is not the way I really need the information. I need to know it's the 4th day of stay. Now, those of you who don't use the date, do you do that? Yes! Like you. Good practice. Because that's really what we want to know, is how long have we kept these folks captive? That is innovative in my definition. So the other one I like is, how many of you have listened to bowel sounds to determine whether or not you should be able to feed a child? Oh, so we all do that one. Do you know that that is the least predictive about whether or not they're ready to eat? They don't come back uniformly. We do the present in all 4 quads like it matters. There's nothing behind that. Nothing. It's a tradition. The best predictor about whether or not a patient, child, or adult is ready to eat is, do they want to? It has nothing to do with their bowel sounds. So if you want, I can give you the literature on the whole bowel sound thing. But understand that we do stuff because somebody taught us to do it, not necessarily because it had good science behind it. So tell me about your favorite tradition that you have figured out is not really relevant to your practice.
Never say you're having a quiet day.
Never say you're having a quiet day. This is a tradition because it always turns around. Yeah. Okay.
According to chloroseptic, for the chlorap, exactly. We used to always clean the site,
In circles.
And so when chloroquine came along, they recommended, and boy, did we have a debate over that at that time.
We're still having that debate because not all of us have read the ChloraPrep package thing. And so our policy says do this. And then someone points it out and they say, well, no, we do this. Because we've been using this product for a while,
Right.
longer than my lifetime here, and I have participated in this debate.
Right. But as it turns out, there is no literature that shows that doing the circles, well, we couldn't find any other.
No, it's what we all learned.
We all do the prediction.
Right. All right, anybody else got some faves? Come on, there are things about your practice you have been all practicing for a while that you figured out was just stuff you did. If not, you have not oriented nearly enough people. Yeah. Why is that? Because the role of the orientee is to ask you, why do we do it this way? Because at my old shop, we did it this other way. And if we're answering those folks with, this is the Lucille Packard way, we are teaching them to practice in a way that we would not like to support. We should have a reason for what we do, not just because it's the Packard way. So, always encourage your orientees to question what it is you're doing, whether they're new grads who say, in school I learned, or folks coming from another environment who say, that's an unusual approach to this problem. Because if you're not listening to what they're questioning, we are not able to fix our practice. So when I think about how it is that we take those questions and set ourselves up for great practice, think about, we are all learning to love and hate the hack work. But how many of you have changed your understanding of how long 15 seconds really is? It's like a century long every time you scrub the hub. You've learned new songs to sing, but you have all learned that singing songs is a requirement. I'm reading a book currently whose name I should remember, but it has something about checklist in the title. But it's about applying checklists in healthcare, and it is absolutely fascinating. And I'm sure we're going to have more and more of these. Chris is back there shaking his head going, you're reading the same book?
Checklist manifesto.
Yep, that's it. Thank you. It's a great read on how we can take what other people are doing and integrate it into what we think is our overly complex world, when much of it is a bunch of simple stuff strung together, and those things are all amenable to checklists. We're getting really much better at it, so we remember to do the simple stuff that presents harm. But that's what innovation is about. It's what transforming our world is about. It's about thinking about new ways to do things, and about not having tolerance for our current approaches. We all know that I am here with you for a brief period of time, and part of what I want to leave you with is a real understanding that questioning your reality is critical to your practice. And we will get to it is not an acceptable timeline. If we've identified a problem and we're putting our practice, our children, our mothers at risk, we need to have a way to get from where we are to where we get to the perfect solution. But tolerating the status quo is not one of our options. You are our innovators. You need to be looking every day at your practice, at the practice of your colleagues, and saying, are we doing the best we can do for our patients? Because that's why they're coming to us. You know, they could go down the street if they wanted community hospital service. They're coming to an academic medical center because they expect to get the best of the best. And that's what we need to be providing them. And that's what you do every day when you come to work. I am incredibly proud to be part of your team for this period of time. So that's my thing on innovation and tradition, is to question your reality. Tradition is a fine idea, but innovation is what's going to move us into the next phase of our lives. Change, although stressful, is great because it keeps us moving. I think learning is the wonderful thing about nursing, is you never know it all. Okay. So, it's your opportunity to introduce Lisa.
Flowers for you. Susan.
Oh, flowers.
Thank you. Thank you. All right. Thank you, Susan. Next, we have Lisa Grissom. Get her presentation up. My son. All right. So, Lisa Grissom is an RN who has worked at Stanford University Medical Center in various nursing, education, management, as well as IT roles over the past 28 years. Lisa is currently the Associate CIO for Clinical Systems with responsibility for the IS Project Management Office, the IS portions of PCHA, Packard Children's Health Alliance, as well as being the Clinical Project Director for the EPIC implementation, both inpatient and outpatient. So we welcome Lisa.
Thank you. Thank you so much. I'm really excited to be here today and to represent all of the amazing, fabulous nurses that we have on the EPIC implementation. We have over 50 nurses that are contributing anywhere from full-time to a 0.2 of an FTE and in between to the EPIC implementation. These are people representing nursing practice here at Packard that is really pushing the boundaries and looking at where we're at today and where we're going to go in the future with EPIC. So I just want to start with a disclaimer. This presentation is not meant to be a comprehensive overview of the EPIC implementation. They told me I had 10 to 15 minutes and, I could inundate you with, 50 slides and then you'd fall asleep and you'd walk out of here and say, that's not cool. So instead, I thought I would highlight some of the really cool things that are being done as a result of the EPIC implementation. So starting with our EPIC project vision, and you've all heard that we're converting to EPIC, correct? Yes, good. Okay. So the EPIC project vision, to enhance the delivery of extraordinary family-centered care, our true north as an organization, by developing a comprehensive, integrated health information system across the continuum of care. So I wanted to highlight those three things: comprehensive, integrated, and across the continuum of care. We don't have that today with Cerner. Any of you here when we had Meditech on the front end for results? And what you may or may not know is we still have Meditech. It's on the back end for billing. the organization had made the decision that Cerner didn't have a billing system that was fully baked at the time we implemented Cerner, so we kept Meditech. That is something that we are going to replace with Epic. So getting to that integrated. We also have another system that we do pro-fee billing for in the clinics. It's not integrated. We're going to get there with Epic. So why are we converting to Epic? Those three things that I highlighted, comprehensive, integrated, across the continuum of care. This is our current, I put Northern California Epic environment because, as my boss says, we are an island of Cerner in a sea of Epic. All major Bay Area hospitals are either on Epic or are converting to Epic. Stanford Hospital, down the hall from us, on Epic. Oakland Children's converting this fall. John Muir in the process of converting to Epic. UCSF went live recently this past year with Epic. All Sutter Health Hospitals, CPMC is in the process of converting to Epic. Kaiser is on Epic. One of the things, and I'm going to talk about this tool in a couple minutes, one of my cool things that I'm going to share with you, is going to get us to that pediatric patient record. We're no longer just interested in just what's happening on our inpatient environment. It's across the continuum of care where we're looking at it from the patient and the family perspective across the continuum of care and having the data available. So since I am in IS, I'm going to put one really complex slide up there. I'm not going to spend a ton of time on it, but this just highlights all of the major strategic initiatives we have going on in the organization. The EPIC project being one. We're rolling out systems in Packard Children's Health Alliance, currently doing eClinicalWorks for practice management and an EMR. We have lab system. I don't know if any of you know our lab system is going to be converted. Where Stanford Hospital is converting to the Beaker system, which is within Epic, get us more integrated with our lab system. That project will be kicking off this summer and then going live February of 2015. Got all the PeopleSoft stuff going on. We had our payroll change that happened. So a lot of stuff there. I want to highlight just the key Epic dates and at a high level, what is the scope of what's going live when. So next May will be our, what we're calling the Big Bang Go Live. And that includes everything that's currently on Cerner, plus the revenue cycle pieces on the back end, the billing that I was speaking about before. That'll be in May. We're also at that point going to be doing a first initial set of clinics where we will be automating all of their clinical functionality, orders and documentation that's not currently live in Cerner. Then in early July, so about 60 days later, we will be going live with our Packard Children's Health Alliance. Have all of you heard about PCHA to some extent? The practices that we're bringing live on eClinicalWorks right now, we're going to convert over to Epic so that they will be on our Epic system as well. And then 30 days after that, so in August of 2014, we will be going live with all of the remaining clinics with full clinical functionality. And so that's aggressive. It's a lot of stuff that we're doing in a short period of time. One of the big drivers of that is something called ICD-10. The whole nation is switching from ICD-9 coding for billing to ICD-10. It's increasing the number of codes and the specificity there. That compliance date is October of 2014. There's a lot of great reasons why we want everybody to be on the same system for documentation and for billing come that date. So that's why we're compressing a lot of things in a short period of timeline here. So, the top 5 cool things for nurses. I don't know if any of you have been to the heart-to-heart class. Have any of you been to that with your daughter? I went last night with my 11-year-old daughter. And the instructor for the class, Mary Patterson, fabulous. I don't know exactly where she reports or who she reports to, but she was fabulous. And she was talking about the hit parade of puberty. You know, I'm sitting there next to my daughter, and she was talking about the top 6 cool things about puberty. Well, you're not going to see any of those 6 things here, but we're going to focus on the top 5 cool things for nurses. A lot of cool things for nurses with the Epic implementation. So in the style of David Letterman, I'm going to do it as a countdown. So number 5 cool thing for nurses about Epic is Care Everywhere. So this is the tool that will allow us to share clinical information with other organizations that have Epic. And again, there's the list in our area of organizations that have Epic. And Epic, this is where they've gotten it right, for sure. They have a very elegant solution for being able to not only share clinical information across sites with Epic, but the clinician has the option to actually download that information into the clinical record. Powerful, powerful stuff. Very cool. So number 4 on the list of cool things, EMR integrated specialty applications. Now this might not, this 4, which actually is 3 things, might not apply to everybody in this room, but it's so cool that everybody in this room should be excited about this. Beacon is the application within Epic for chemotherapy protocols. You may know, if you work in the BASS Center, know about the BASS Center. We've not automated in today's world chemotherapy protocols. That is still on paper. It's hugely complex to automate that. And obviously, especially in pediatrics, it needs to be done correctly. It spans inpatient and outpatient, and Epic has done a really good job of it, very thoughtful job with Beacon. And we are collaborating with other children's hospitals to make sure that when this goes live, it truly is going to be cool and enhance patient safety and the care that we deliver to children on chemotherapy. Another one is Stork. Epic's got these great names. Stork for obstetrics. Again, obstetrics, inpatient, you have all your, your 9 months of visits, and then labor and delivery and postpartum. And this is all integrated within the Epic system. And the final thing is Phoenix, which is for transplant. Any of you use Otter today? Otter is our current transplant system. It's a great system. It's a niche system. It's not integrated with Cerner. Therefore, we have about 8 interfaces of data between Cerner to Otter so that the transplant coordinators and transplant doctors will have the data that gets entered into Cerner in Otter. It's not efficient because you can never get everything you want in an interface. So people double document in both systems. Phoenix will allow us to enter the data once in the system. Anybody who wants it can see it. Very cool. Number 3, support for real-time nursing documentation. So real-time nursing documentation, you have an EMR that's integrated and accessible to anybody that uses it. But if a nurse goes to the bedside and does her assessment and writes information down on the paper about the patient and takes that piece of paper and sticks it in their pocket, someone goes into the system, we've got great clinical decision support in the system. If the data's not there, people can't see it in the pocket. So what we're doing, this is being led by Judy Tidwell and our SMEs, our subject matter expert nurses that are working on the project, are going out there and doing time and motion studies on the nursing units and also surveying the nurses. What are the barriers around doing real-time documentation? We could be doing a lot of that today. It's not rocket science. In the ICUs, where there's computers at the bedside, guess what? For the most part, the nurses are doing real-time documentation. They're delivering their care, they're entering the data in the system. In acute care, where there's not a device at the bedside, the nurses it's a barrier for them for doing real-time documentation. You all know, the rooms are small, we got a lot of equipment, trying to lug a cow in there. We're not enabling the nurses, we're not supporting the nurses to do real-time documentation. So we're going to, all of this program is going to be including a device assessment. One thing I've learned is one device does not fit all. Different people work differently and like to use different types of devices. We're going to do a device fair where nurses can come and look at different types of devices that will help enable their workflow. And then last, I just wanted to highlight mentoring and support. There are some nurses out there that, even in the acute care units, are doing real-time documentation. How are they doing it? How does that work for them? How do they overcome some of the barriers? You know, we really want to leverage people and help and mentor each other and support each other. So, number 2, and this is going to help support number 3, is barcoded medication administration. How many of you have used this at another hospital? Right? We need this. This is one thing that with Epic at our May Go Live is going to be new and very cool. We will doing barcode medication administration. 5 rights of medication administration. It's the right patient, drug, dose, route, frequency. And this gets us to the 6th right, documentation. Real-time documentation, correct documentation. What was given when it was given. Our nursing SMEs have been involved in looking at workflow redesign around this, equipment selection, the scanners. Scanners got to work, or barcoded medication administration will be a very frustrating endeavor for the nurses. And of course, policy and procedure development. So the number 1 coolest thing about the Epic implementation, this at the end of the day probably won't end up being the most important for nursing practice in the future, but to me, so cool. And that is our training location. We are going to be training staff in the Stanford Stadium skyboxes, and this is not a joke. We are really going to be doing this. Yes, very cool. We are super fortunate on the project to have just an amazing training team. All of our teams are amazing, but we have Bethany Goad, who's back there leading our training effort. We have Amy Nichols, who's involved in the content review for training expert people. And we have a very special person that I've known for years. We worked together at Stanford as nurses. She was a nurse at Stanford and was a Stanford coach for 20 years, taught synchronized swimming, and took the team to the NCAA championship, I'll let you know, and was named Coach of the Year. Quite accomplished. Anyway, she's got some connections with Stanford athletics. And so as we were looking for where are we going to train over 5,000 people in 6 to 8 weeks, close enough to the hospital, that has parking, that, it was a real dilemma. Vicki got the bright idea, the Stanford Stadium. When it's not football season, beautiful stadium sits there empty. Tons of parking, close to the hospital. And so I went to look at it. I've never been into the skyboxes. I don't know if you all have. There's actually 3 levels of skyboxes. They're gorgeous. This is not traditional training space. But it's cool, and we're going to make it the best training that people have ever gone to. And I'm confident about that. There are 26 rooms. They're equipped. They're used to having press there. We can use Stanford catering. Anyways, as you can tell, I'm very excited about this. And so to Vicki. So do we have any of our SMEs in the audience? Stand up, our SMEs. Jenny, is anybody? Here's some of our SMEs on the project are in this picture. These are the people that are really going to be making this successful when we go live. I mean, I just am so appreciative of the work that these people are doing. They are really looking at what are we doing today, what are the traditions. The admission database over time has grown, those of you who use it, to be, why are we documenting all this stuff? They're taking a real critical look at that, and the new admission database is not going to be as long as the one we have in Cerner. So they're just doing a great job. And then our EPIC program nurses. We have 27 RNs in the IS department. And I just feel so fortunate every day when I come to work that I work with these amazing people with expertise and experience and just have such a passion and a drive for the work that they do. I am able to be successful at what I do because of the people that I work with. So thank you all. We are going to be having a website coming live soon. We'll send information out about that where you can get all the nitty-gritty details of EPIC. But thank you.
Thank you so much. All right, so that concludes our keynote speakers. We'd like to move on to our expert panel. So we have Charlene, Deo, and Elena Hopkins. If you could join me in sitting up here at the table. So Elena Hopkins is a nurse practitioner here at Lucille Packard with 54 trips under her belt in her 30-year career as a pediatric nurse practitioner. She's assisted in hundreds of surgeries for cleft palate, burn, reconstruction, and pediatric primary care. She's traveled internationally.
Okay, that's fine.
Hello. She has traveled internationally. Her most recent trip was to India. We also have So if I could ask maybe if you guys could introduce and tell us a little bit about what you do, and then we could open it up to questions and answers.
Do I need to use this, or I can talk loud?
You can talk loudly, but it
They need
won't
to-
really be on the tape.
Tape.
So if you would use it, it'd be great.
Use this. Hi, I'm Elena. That made me sound like I was 79 years old. So that was extremely concerning because I don't feel that way. I went on my very first trip when I was a new grad. I'd been a nurse for 2 months, and Eileen Garrison was my preceptor. And
That really makes me feel that
And had it not been for Eileen's amazing training, I probably would have not survived that trip. So that was my first trip, and so I've been really, really lucky and have been able to go on 2 or 3 trips every year since. I started out as a recovery room nurse and have been in the OR. I've gone as the nurse practitioner doing the pre-op screening. I've gone as the nurse educator. I think, if anything, my message would be that there's basic nursing that we all, is the core of what we all do. And I think that is what will come back to serve you on any of these trips in any country with any colleague that you work with in a third world country. So that is my, that's really my strongest message. And I feel like I learn more from every trip that I've been on than anything else that I can show anybody. So I feel very, very fortunate. I'm happy to chat with anybody about the groups that I go with. I've been with probably 7 or 8 groups. And I think there's amazing opportunities out there, but you do need to be really, really persistent and energetic, because they do have great pools, but the squeaky wheel, the more emails you send, the more likely you will get to be on a trip.
So hi, I think I know mostly everybody in this room. I'm Charlene. I'm your wound ostomy continence nurse, and grew up mostly here in Packard, being in the neonatal ICU, and then moving on to the telecenter and the PICU, and now with this pretty vast role of everything that kind of lumps my way. In terms of innovations and traditions, I think over the last 5 years, that's one of the things as a group of nurses that we have done together the most. Everything from asking the question, why are we using this bed? Why are we still using this gel pillow? Is this the best thing for our patients? What is the best thing? How do we support quality, as nursing quality is being measured in so many different ways? And I think it's through the group work, conversations, constantly asking that question, are we doing this the best way possible, that we've been able to get Packard to this point where we have kids on ECMO for a month and not have a pressure ulcer. My hope would be for Packard that we keep asking that question. Are we using the best product? Is there science behind this? Why should we not use the egg crate? Should we move on to better products? As I look at the products that we have now available for us in nursing, I think we're right at the top of the line in terms of cost, outcomes, and products. Do I anticipate things coming in the future? Probably not for a couple of years because we're really right there with technology and silicone and how we're using it. But it is very exciting for nurses to see how nursing is pushing practice at this hospital. And we have lots of work to do teaching many others. But yeah, it's been a wonderful journey working with everybody here. And there's that thought that the leader comes up with the idea, but you need to have the team that's behind you. And that's definitely what it's been. It was the leader with a crazy idea, and everybody kind of jumped in and said, yeah, this sounds good. So I really thank everybody for that and look forward to seeing lots of different evidence-based practice literature coming out from all the different nurses and all the different units and how all these products work.
Does anybody have any questions for them? Yes.
It's probably repeated in the mic, but Charlene, how did you get into this role, because I know I met you when I first started here, you were one of the first nurses. How did you decide that this is kind of your passion?
So you asked how did I get into the role of the wound ostomy continence nurse? You really want to know the answer?
Yes. Now I desperately want to.
You do too. So this is where you're going to laugh. So I had a 2.5-year-old and a 9-month-old at the time, and I was working in the PICU nights. And I was like, this is getting rough, because my 9-month-old is very active. And I said to Patty, I don't know if I can keep doing the PICU, because my 9-month-old son doesn't let me nap during the day at all. And Claire Abrahana from surgery came by, and she said, this is a perfect job. It's 0.5, it's going to be really easy. And I thought to myself, well, I've never paged the WOCN, so this has got to be a good gig. And that's the honest truth of how I got into the role. But regardless of how I got into it, I realized it was a passion. When you do the training out of Emory and you realize what a difference you can make, it was the best thing that I think I've ever done because I've been able to make a big difference. And I encourage every nurse to take at least a W training. You just don't get that basic info in nursing school. And then when you get out into practice, there's so much going on that we kind of forget a little bit of our basics. And we don't have time to go back and find the evidence for that. But that W training is phenomenal because it brings it together. And as when we took the first group of nurses through the W program, I said to them, each one of you will be able to apply this knowledge in a different way on your unit and your practice. And that's what we've been seeing. So through that journey, we are offering, for the first time ever, on the West Coast in California, in a long time, we've collaborated with San Jose State to open up a W program. This will be the first time. And accreditation will go through in October, and we're going to partner up with Lucille Packard and the Center of Nursing Excellence for space and resources. So this is pretty exciting. I'm hoping to see lots of Packard people again. Yeah.
So I just have a question for Elena. Elena, what was the biggest hurdle you had to get over to get yourself moving down the path of doing volunteer work internationally, working?
And Elena, if you could repeat the question.
What was the biggest hurdle in starting the work, in getting I think probably getting my husband to agree to watch the kids, honestly. I mean, I'm being totally honest. I think that people ask me that all the time, and the hugest impact has been, I think, in coordinating, and I think everybody in this room feels the same thing. I feel like I'm constantly juggling, and if I drop a kid ball, it's not good. So I felt like my work life has always been extremely supportive. I'm so fortunate. But coordinating, I feel like I needed a village to make sure that all the kids were in the right place and that my husband was going to be okay. And we're talking a week to 2 weeks. And as I would say, okay, I do this 24/7 year-round. This is 2 weeks. You can do this. But honestly, it was just the coordination of that. And then once you start doing it, it's almost addicting. The ability to be so focused and to really have such a huge impact in the quality of life. We're talking a 1-hour surgery. The surgery that I do is reconstructive, mostly cleft lip, cleft palate, and burn. So it's a 1 to 2 hour surgery for kids that have either been hidden in their villages never come out. They are not allowed in school because there's a lot of myths that it's contagious and that families don't want them exposed. So to impact a child's life that much, it's really hard to not plan on going back the next time and not dream about it.
Cool, thanks.
Charlene, what are some of the traditional wound care processes and devices that are still out there, maybe not used here, but that you think are still being used and considered, conservative therapy that are harmful?
So your question was, which wound care processes out there that are traditional and still used and probably not the best? Wet to dry dressings with gauze. That is my hands down. If I could just get rid of wet to dry, it'd be so nice. There's no evidence on it. You look in the literature over the last 5 years, nobody has published that wet to dry works well. It's not antimicrobial. It dries up in the wound. You go to pull it out. The kid cries. And over the last 5 years, lots of beautiful dressings have come out. So that would my one favorite to get rid of would be wet to dry.
So then what's your go-to?
Well, it depends on what the wound is like. I would want to use a hydrogel or Medi-Honey, which is antimicrobial. Hydrogel is a moisture that lasts longer. I certainly wouldn't use a regular gauze on a very expensive surgery that you've done. I'd want to use something that's got antimicrobial in it.
And Medi-Cal covers all of it.
Absolutely. Medi-Cal is actually now saying that if you're using wet to dry, you better document your literature on it. And if you get a surgical site infection or an infection from a wound and you've done non-advanced wound care, you better have a rationale for it. So Medi-Cal is kind of catching up and driving care as well.
I work with surgeons who do only wet to dry.
So, as I say, it's going to be nursing that drives best practice. Nursing will drive the best practice for this.
So you're meeting with her surgeons later today?
I think they go the other way when they see me coming.
Follow up on the hydrogel question.
Yeah.
I'm not sure if you're aware, but there was a product for nipple care healing, wound healing. Do you have any experience with that, or?
So the question was hydrogel and nipple healing.
Yes.
There's actually some real nice ones that are coming out that you can use on cracked nipples, and they're safe for breastfeeding. And the product company is Dermascience, so that's something that we could bring into Packard, and it would be quite nice. FDA approved that, okay for the babies to nurse after it's been on the breast. Yeah.
This question is for Elena. What made you go to your very first trip?
Repeat the question.
Why did I go on my very first trip, or what made me go on my first? Again, Eileen was my preceptor. It was one of those, when you look back at how things happen, I think a lot of us have had this experience. I happened to be in the unit when the founder of Interclass walked through, and the unit clerk knew that I'd always been interested in the Peace Corps, so she said, go talk to him and find out, if you can go on a trip. And I was terrified. I didn't know what I was doing. Eileen said, go talk to him. Go talk to him. So she went. You don't even remember this. It's Dawn Lau, who is still around, actually. And you went and said, this is my preceptee, and she really wants to go on a trip with you.
Sounds like me.
But, I just look back, and it was all just kind of happened at the right time, and it was really life-changing. And I was totally overwhelmed. They were running 4 rooms. I was the only recovery room nurse. I'd only been a nurse for 2.5 months although an amazing preceptor, I was really in way over my head. I think most organizations are getting much more strict as far as the requirements. You have to have a certain amount of experience. They don't take new grads, which I think is a great thing. But probably because of me, that rule has been really enforced. But I really do believe in other people I know that do this kind of work is once you start, it's very difficult to not continue to do it.
I have a question for Elena as well. Can you talk a little bit about the numbers of families that come to the clinic, when you're in overseas, like the numbers of people that come to the clinic and how many patients you're usually able to actually do surgery on your visit?
So the majority of the trips that I go on are pediatric reconstructive, so cleft lip, cleft palate, when there's a lot of burns in third world countries because they use kerosene to cook. And the children are the closest because they're usually ground fires and they're flash burns, and they put up their hands to protect themselves. So their hand, face burns. So it's usually 50% cleft and 50% burns. And on arrival, what they do is 2 to 3 weeks before arrival, they announce in the newspaper and in the radios that this group is going to be coming. The problem is most people hear that and they think it's an American group of surgeons, so everything shows up. So it's usually anywhere between 800 and 1,000 people that are just lined up. And they travel for days to get there, and they're just hoping that somehow their child can get services. So the first 2 days usually, we always think it's going to be one, but there's always overlap, is the clinic day where we triage. And we tell the club people that, Operation Rainbow, that there are groups coming, and then we try to do the youngest first. And invariably, there's always adults that still have not had their clefts repaired and or have really horrific burns. We put those at the end of the schedule. Our priority on the groups that I go with are all pediatric. And so we could do anywhere, but it depends on how many people are in the team. If we're running 4 rooms, then we can do anywhere between 200 and 300 surgeries in about 10 days. On the smaller groups, the most recent trips that I've been on, there have been smaller groups just because the nonprofits are having a really hard time getting donations. So the numbers are much smaller, there's fewer trips, so there's only been 1 or 2 surgeons, and so we're lucky if we can do 100 to 200 surgeries.
So we want to thank Elena and Charlene. Great resources. If you have any further questions, I'm sure they would be happy to answer. We'll have some flowers. Oh, nice. Thank you so much. So I'd like to have Liz Austin come down, and we will have 2 educational speakers.
Good morning, Packard nurses. Yay! It's so exciting to be a nurse. We can actually talk socially about dressings and wound care, and nobody's going to get grossed out, right? And I just want to thank everybody for being here today. It's so exciting. And I just want to say Amy Nichols put the Train the Trainer on her timeline. That's so exciting. If nobody knows anything about the Train the Trainer transcultural training, the Education and Professional Development NSL Council invited 3 nurses, national, from across the country, Tennessee, Nevada, and they shared how to be cultural competent nurse, which is one of the national patient safety standards. And if you want to know anything about it, the people who attended that were mandated to teach 5 other people about that. So my cliff notes on that is, my daughter's a wrestler. Yikes. So how do I relate to her and the other wrestling people? So that's my little, you don't take pom-poms and their name on a poster board and cheer for your daughter. Okay, it's really not cool. So anyway, she's the only girl on the wrestling team at Palo Alto High School. So I'm Liz. I'm the chair of the NSL Education Professional Development Council here at Packard. And my vice chair is Michelle Santillano, and she set up this invitation, so I'm very proud to introduce Debbie Casey. She's a staff nurse 3 working in PICN, and she's going to talk about what LPCH is doing in the community. Yay! Does everybody have a handout? There's like 3 handouts on your way in, okay?
Oh, sure. Sure. Sure.
Hi, good morning, or almost afternoon. And welcome to Nursing Grand Rounds and Happy Nurses Week. I love Liz, she's so enthusiastic. Thank you, Liz. My name again is Debbie Casey. I've been a nurse here at LPCH for 17 years. And I started my career here in the Parent Information Referral Center, Telecenter. I don't think anybody knows what it is because it sort of dissolved about 10 years ago. But that is where I first learned of some of the community programs that are being offered by the hospital. So I currently work in the PICN, Packard Intermediate Care Nursery, and the Well Baby Nursery, actually, and really enjoy, like most of you as nurses here at the Children's Hospital, teaching and nurturing these families, and especially for me, these new babies. So I'm here today, just taking a few minutes to let you know just what LPCH is doing here in the community. I started teaching what's called the Newborn Care 101 class about 10 years ago. Then I took a break to have 4 kids of my own, and was thrilled to be able to come back just about 2 years ago and teach again. So I know 10 years ago I didn't have any kids. I was a little intimidated. I got in front of these crowds and I thought, and I didn't even want to admit I don't have kids. But I took care of babies and I did pediatrics, so I still knew a little bit more than they did. So that was where I got the confidence. But now I'm back, and now I have 4. I have 3 girls and a boy, so I'm able to help them with everything. So it's really nice too. Some of the parents that I have been teaching kind of come full circle because they sadly ended up on my unit in the PICN, but I have seen them roam through Well Baby. So it really is I find to be very rewarding and come around full circle for me. When I mention to my coworkers that I teach the class, I'm always met with, what class is that? Where do you teach it? Who teaches that? What do you talk about? So it was something that in my education lead position with NSL, I thought, I met fellow nurses there as well that had no idea about these classes, even the simple Newborn Care 101. So I'm here today to sort of let you know, there are lots. I may not do justice to every one of them, but I'm hoping to touch on a little bit of them. So the lpch.org website lists the events and classes that are offered to the community, so I would invite you to peruse that if you might have any friends that are going to be becoming new parents or are parents. So they really do offer quite a lot on that website. It's under Your Child's Health University, and it's a series of programs and classes and really to enhance the lives of parents and their children. So to start, before birth classes are very popular. Newborn Care 101, which is the one I teach currently. It's really fun, it's really interactive, it's a 3-hour class, and this is where we get to teach these really newbie parents how to basically take care of their babies. So it's always fun to watch them get a diaper on a doll, do a bath on a doll, do a temperature on a doll. So I really find that to be very enjoyable, and they really seem to appreciate it after they leave. We also have, of course, childbirth prep classes, which obviously focus on labor and delivery of the baby, provide an overview, and emphasize the many variations within a normal birth. We go over relaxation, breathing techniques, medication options, hospital interventions, and immediate postpartum information as well. There is also a class called Comfort Techniques for Labor, which kind of goes hand in hand. This is a 2-hour seminar. It provides practice and creative tips for dealing with labor through a variety of comfort measures, and the emphasis is given on partner participation in that particular seminar. Also, cesarean birth classes. So this is a 2-hour class. It's not only for the few people that might know in advance that they're having a C-section, but also those who wish to really be fully prepared for that 1 in 10 chance they might have a C-section. We have a wonderful breastfeeding seminar. I'm not sure if we'll get a little bit to talk about that. I can't do it justice here talking about it, I'm sure. But to go over the benefits of breastfeeding, because as much as they are widely known, the process is not always obviously easy and intuitive. So I think this is an awesome class. I recommend it to my class because I cannot really even touch on it in my newborn care class itself. So we have certified lactation consultant educators, and they share their ways to help moms and babies adjust to this new experience together. It's awesome. So along with the before birth classes that I just mentioned, we actually recently brought over a Becoming Parents program. I have some cards to hand out, and I do have a little bit here on my poster board. So this is a workshop that they've most recently introduced. It's being offered for expectant couples, but also for new parents in the first postpartum trimester. It's a class taught by certified Gottman educators, the Gottmans being world-renowned pediatricians. I kind of wish I had something like this, because what they learn what to expect during the transition to parenthood. Then they also learn how to strengthen their friendship, intimacy, conflict regulation skills, and also learn about child development and how to co-parent with their partners. So it's a really great co-parenting, team building, I think, program. And it's very recent. It's awesome. I know they're certified instructors for that class that they just started. We also have, of course, infant safety classes. Infant CPR is, of course, offered here. But what's pretty popular that we always like to promote, if you all already don't know, is our awesome car seat fitting station, because as you all know, 4 out of 5 child safety seats are used incorrectly. So this program provides the certified technicians and will instruct and demonstrate how to install and use appropriate safety seats. So it's something that we have here. I hear he's awesome, and everybody I refer to as much as possible. And of course, we would have also after-birth classes, and these help parents and families adjust to their new arrivals. They'll provide safe, soothing environments for their babies. We have, which I've facilitated also, is mother-baby mornings, new family coffees. These are for 0 to 6 month babies. And there's movers and shakers group. This is for 5 to 10 months. So it's kind of your little mommy mornings and mother-baby mornings that are also being offered. So, and even more classes that are being offered, which I've also taught in the past. Sibling preparation class, that's really kind of cute. They get the small siblings to come over. We do a little activity with them. They get to tour the nursery, go look at a room. So it's really a nice preparation time for siblings as well. We have preparing for multiples. We have a grandparent seminar that I know is quite popular as well. And we have prenatal Pilates also. So we're really proud to collaborate with our community partners that ensure our community's children and families are healthy and happy. Most recently, we've established a corporate sponsorship with Apple, I was told. Other recent community events, we had a Kohl's, a department store car safety seat checkup event, the 6th annual Santa Clara County Children's Summit. So we really are branching out quite a bit. It's really become a great program. So everything that I have talked to you about today is brought to you by what is called the Packard Children's Government and Community Relations Department. My focus really here today wasn't to kind of recruit all of you to come teach. I don't think there's a huge need. Felice, who is the coordinator, is happy to take out any resumes, because it's always good to have backup instructors. But we have even outside educators, so I think she would like to see more of Packard nurses, and I think even the patients ultimately. It's really come full circle to be able to see us, and I've been happy to be able to see them after I'm like, how are you in your class? You're going to know everything. So you're more than welcome. I have her a card here with her phone number if anybody's interested. But I'm hoping, I just wanted to get the word out. There's not a lot of people that knew about it, and I think I'm really proud of it to be part of this hospital and to represent and do these classes. I really enjoy it. I think the families really enjoy it. And I invite you to come and take a look. Any questions? Questions? Thank you, everybody. Thank you.
Yeah, you have some, or you can, perfect, here's your thank you. Thanks so much. Good job. Yeah.
Isn't it amazing, all the things they're doing here? It's great. Great job, Debbie. So she has some handouts here on the Becoming a Parent program. Very nice. So I now have the honor of introducing Mahar Jahan. She is a master's prepared, recently earned clinical nurse 3 from 3 East. and she's going to talk about preoperative teaching for spinal fusion.
Hello everyone, my name is Maria, and I'm from Trees, and I have been graduated from USA recently, and so today my topic of the presentation is about the preoperative teaching and education for spinal fusion. So we actually selected as our final project from school, and we selected the name of Hospital Operating Orthopedics Pre-Admission Education. So the reason I chose this topic, it was basically the need of the pain management and post-operative recovery for most of the patients on medical surgical floor.
I think we got it.
So the purpose and the main goal for my project was basically to implement a new preoperative teachings as a complete, covering most of the needs and educational needs of the family, especially emphasizing the families, and also to approach a multidisciplinary team, basically interventions. And finally, we try to basically improve the pain management, post-operative care, and finally the outcome of the patient, and also reduce the length of the stay and complications. The most of the objectives we try to cover from the pain management, I was noticing that some of the pain management review, for example, like the PCA and epidural teachings is not very complete usually. And if the patients, they have any respiratory issues or any complication as a post-op. And also the main part is about physical activity, the basically physical educations, orthopedics educations that we need usually as a post-op. And finally, again, we can improve the communication between the patients and family by nurses. So in order to implement these pre-educations, basically we can address many of the goals and forces of the magnetism of it as well for the LPCH in basically missions, that some of the forces, for example, management style, quality improvement, autonomy, nursing educators, and also the interdisciplinary relationship. And in order to achieve these basically missions, we can again have a better effective communication with the team, and also we can improve the skills of basically providing education for the nurses. And finally, we can use many of the health resources and many resources that we have right now at the stage. So in order to provide the need assessment, I try to focus on the most important teams that they can be involved. So at the first priority, we need to consider on the nurses. They are at the point of the care, basically. They are the main educators through the whole post-operative care. And also the main people that were implementing and forces orthopedics and basically physical therapists. And management, they can be very supportive. And finally, we can talk about social worker and child life, that they are always there. And we need to know that estimated 6 to 9 million people of the US that are actually affected by this disorder. And scoliosis affects 3% of the adolescents patients. And most of the family and population patients from the LPCH, they are coming from multi-different cultures and different languages, and they are having different social, psychological status. And also it's very important to know that most of the girls, they are affected 8 times more than boys or males. And the age is very important in this disorder because at these ages, basically we have more complications for coping. In order to kind of place the interventional goal, my plan was not having a very long, basically, teaching period. So it has to be very short and clear, to be very easy for understand and having a clear expectation of what is the recovery process and reducing the anxiety and the stress of the patients and also the family. So if the nurses, they have a better, basically, teaching plan, and the patients, they have a better understanding of what they are expecting for, so I think both of them, they have a better positive outcomes, and again, eventually is all toward the patient's outcome. And also for the discharge process, we can have a better management. So these are very details. I don't want to go to each items, but basically my major focus was the first priority about the respiratory management. So we can do many kind of teaching about the cough and deep breathing, the using of the incentive spirometer that usually is actually encouraged by the orthopedic services, And also pain management is one of the other main focus terms. Many of the patients and family, they have no knowledge about how to use the PCA and also the complication on some of the narcotics medications. And it's not just about pharmacological interventions for pain management, non-pharmacological is very important. Recently, basically this is one of the main topics that we are working on it on the pain service to kind of like educate the nurses to implement and use the non-pharmacological interventions such as distractions. That's why I'm just thinking about child life and social worker as well. And finally, if by the discharge plan or basically any kind of needs, we can kind of having a better management from the case managers or social worker in order to prepare any kind of follow-up care. Some of these patients, when they become discharged, they need more cares actually after discharge because they have some kind of baseline physical issues or any cognitive issues. And again, the final goal is improving the patient outcomes, reduce anxiety and stress, and everybody's happier. So the major environment and setting for my teaching plan was kind of I was designing, we can actually provide this teaching not even outpatient clinic in orthopedic clinics, but also we can provide it as inpatient. So, but it's very important to consider what's the motivations of patient and family to be involved in this plan. So basically they want to be pain-free, number one, and also they want to avoid any kind of complications. And finally, we need to kind of discuss that with the team, that how we can encourage the family to be more involved. So the 30 days before the surgery, or maybe actually 60 days also is good. It doesn't need to be very close to the surgical time. But again, we don't need to have a huge class. It's just a very short period of the time, very brief and clear for them to understand. Just having a clear understanding and having less stress. So through this educational part, again, we can get help and coordinations and communication with other teams as well, which the main one is the RN as educator, PT and OT, and also the orthopedic residents as a major coordinator of the major surgical team. So we have many barriers, so this part of the barriers can be in two different ways. We have some potential barriers not as inpatient for the nurses, and also we have many barriers for the family and basically the patients. So if I want to talk about many barriers, the major ones basically is the pain, anxiety and stress from the family members, and also the literacy level of the family. Sometimes education is not easy because they have different kind of background, cultures. Sometimes the family, they are not even present at the bedside. We have many kind of issue or psychosocial issue with the families that being there, even the social worker or any kind of support system can be very helpful. And for our nurses on the floor, basically the main one that I can mention is about time management. We are usually short staff RNs, and also they're having a full heavy assignments for the nurses that can affect the teaching plan. But again, I think that through the coordinations and having kind of more compact management instruction design, we can do this. And we have many resources that we can use, some of the DVDs or health system that right now we have it, we can apply through that, brochures or any pamphlets. So again, these are just the main focus topics, but I want to mention two of the major complications as opposed to for the nutritional complication. Usually we are dealing with some kind of side effect with narcotics, and major one is constipation. I have seen many of the patients, they have longer stay just because of these complications. So we need to focus on that, and also we can start some of the basically discharge instructions at the time of the admissions. But having these 30 days before, more complete, more details is helping everyone, I think. And the more teaching that we do, it can, because it can have different kind of methods, but it's not just always about the verbal education and instructions. It can be through the demonstration, and I think that's the best result that we can get from them. Teach back and do demonstrations from the family. And also we can always ask their feedbacks, what they understand, and what's their needs again. Most of the information that we can provide can be in English or any other languages, and we know that we have interpreters 24 hours available. But this is very important to use our resources. So I tried to address two different learning theories for my designing teaching plan. It was cognitive and behavioral, but I think usually it's very important to emphasize on behavioral theory because you can actually practice the teach-back method. So these are actually the main interventions that right now are multidisciplinary. They are doing it, and they are doing a great job. My plan just was having a better, more organized, and more focus on spinal fusion. Like for example, most of the RT, we know that we are doing a great job on the respiratory management or the PT and OT, but if we have a kind of combined design instruction, so we have save the time and reduce the level of the stress and anxiety for both groups. So again, these are the most resources I already talked about it, the computer and screen, the pamphlet, poster, brochures. So we can actually have the ongoing education for our RNs, and it's not just through the basically very dry classrooms or any teaching instructions. We can actually provide that through the health stream, or we can actually provide that as an in-service unit and kind of like presentations. So the major outcomes comes from the main actually important factors such as communications. So again, communication is the most important factors, not even with the multidisciplinary team, but between the families and the nurses. So in order to improve the quality of income and patient safety. So we have some barriers and issues with the communication as well. And I can just mention about the physical limitations of the patients, not just the patients, sometimes the family, the cognitive issues, and also the financial deficits. So I just try to kind of focus on the plan, do a study act as the methodology, very central to understand. So the first part of the plan, we try to do a need assessment to see what's the major need of the patients and family, and decide based on that where we are going based on our goal. So on the do part, I try to kind of focus on the implementation and interventions, how we want to place these projects, and what we are using for that. On the study part, we can provide some feedbacks and analysis through the voice of the customer, and then see what's the result and what we need to work on it more. And the on-act part, basically, you can do any kind of motivations to improve your outcome and changes on the plan. So as any other projects for educational basic plan, we have all the weaknesses and strengths. And most of the strengths that I can see as a part of our team, so we are very highly skilled clinical staff, we are very highly educated, and we have a great team. But on the weakness side, I can talk about, again, the shortness of time, limitation, anxiety and stress, and also very highly dynamic floors. We have many kind of different patients as post-operative, and sometimes it's hard to focus on just spinal fusion. And also from the family side, I can see that the best motivation that we have for them is just improving their outcomes. But from their negative side, I can talk about, again, the stress and just not being involved and concentrated. So this is just a small, tiny pilot project that I implemented last year as my final project. So what we decided to do this teaching as outpatient in the orthopedic clinic. So I remember on the May and April on 2012, it was almost 6 patients that they have been scheduled for the spinal fusion. From these 6 patients, we try to focus on 4 of them because they have been involved and they have been actually happy to be involved in that teaching class. So it was kind of very short, almost 10 to 20 minutes of the teaching, and we tried to kind of get a very feedback about how was the effectiveness of the class for them, the instructions, it was clear or not, and was any changes for them. So this is a very brief result that we get from that. So the first basically survey that we did from that 12 family members, just 4 of them, they have been agree about the plan, but there was not any actually major result that if they think this is very helpful, if they think this is going to be very useful for them. After providing the teaching, so basically almost 9 of these family members, they have been happy, and they kind of have a better understanding and clear expectations and less stress. So on the evaluation and recommendation part, I have 3 different major groups. Just consider RNs as a bedside nurse, and also the recommendations for the team and for the family. So for the RN parts, I think that we need to focus on ongoing educations, unit-based competency and service, and also we needed to focus more on our focus time, which was 5 to 10 minutes with the family members, to see what's the main needs, not just physiological, psychological as well, if they need any emotional support, any family support, any other issues that can be involved with the recovery plan and make them more involved. And finally, we can actually ask them for feedback. And finally, for the family, we have a follow-up appointment, usually as a clinical follow-up appointment. But what we can actually increase that, 48 hours, just a phone call, and just to see if there is any need. On the discharge plan also, we can work more on that to see if they have any specific needs that can increase the length of the stay, and we can actually prepare them on the admission time. And regarding the RNs, I just want to focus also on basically having some financial support, not just financial, but basically emotional support for RNs. Any RNs that are involved in any kind of teaching, education for the nurses, any project that can be very helpful from the management team and also from the other co-workers. And I think that always there is a barriers. I feel it, I'm a nurse, I know that any changes has some kind of like struggling, but we need to actually be more supportive to embrace the change. And finally, from the team and the whole multidisciplinary, and especially for the orthopedic services, I believe that we need to get more involved and have a more better focused instructional design. So.
So that concludes our grand rounds. I want to thank everybody for attending. Please feel free to fill out a summary sheet. They're located at the back. Your name will be submitted into one of our many contests of attending Magnet Conference. So that is one of our contests. So please feel free to do that. They're in the back and also online at the nursing website. I want to thank Liz, before she walks out, and Education Council for helping us support us in organizing this. So thank you very much.
Okay.